بسم الله الرحمن الرحيم. السيمينار بتاعنا النهارده بعنوان الشيست دايجنوستكس في الاي ار او الرول اوف شيست انفستيجيشن في الاي ار. معاكم دكتور احمد فوده، مدرس امراض الصدريه بكليه طب المنصوره. عشان نعرف اهميه الشيست دايجنوستكس او الانفستيجيشن اوف ذا تشيست في الاي ار لازم نسمع الكيس سيناريو دي ونشوف هنتعامل معاها ازاي. لو احنا عندنا 6 عيانين presented في الاي ار complaining from dyspnea, chest pain and blood tinged sputum, the patient did investigation at the ER. After the investigation, the first patient was admitted to the ICU, chest ICU. The second patient was admitted to chest IMC. The third patient was admitted to chest ward. The fourth patient was admitted to cardiological department. The fifth patient was admitted to cardiothoracic surgery department, and the sixth patient was prescribed home treatment. So we have 6 patients presented with the same complaint. And instead of this, after the investigation, the 6 patients has different 6 ways. This is define or this is highlight the role of chest investigation as a diagnostic marker and to some extent as a prognostic marker of the patients. طيب ايه بقى اللي خلى ال 6 patients دول has different 6 ways. Before we start at the case scenarios or what happened to these 6 patients, we must know the rule of chest diagnostic or chest investigation. The first rule is to confirmation: is it a respiratory system disease or not? Then it aids to reach the final diagnosis and aids to this diagnosis the disease severity. So it can guide the proper treatment, guide the proper treatment regimen, and used as a follow-up measure. So what are the chest diagnostic for ER? We have only 3 primary chest diagnostic at ER. The first one is the chest X-ray. The second one is the ABG. The third one is the ECG. And I mean by ECG not full the diagnosing of ECG, but certain items we must highlight only. As regards radiology, we will have certain radiological samples of the patient you may face in the ER and the clue to diagnose them. This chest X-ray is considered as a normal chest X-ray without any disease. As we see, this is the both lung fields. This is the right lung and the left lung. You know that the left lung is the medial aspect of the left lung is obliterated by the cardiac shadow. This is the cardiac shadow. This is the cardiac shadow. This is the trachea. The radiolucent part in front of the vertebral column is called the trachea. As we see, the lung fields is to some sort dark or radiolucent, but it's not like this. Yeah, the degree of the color here is not like the degree of the color here. Both of them are black, but there is change in the degree of the blackness. Here it's called the jet black. The air outside the body is called jet black, pure air. But the lung has air plus blood plus bronchovascular marking. So the lung is radiolucent, but to some extent not totally black like the air outside the lungs. We have important angles. This is called the post-costophrenic angle. As we see, it's acute angle, must be free of any abnormalities, must be black like the color of the lungs. Then we'll go next to the first disease. This 3 chest X-ray has the same abnormalities. When comparing with the previous one, here we have obliteration of the clear field of the lung like this. This is clear or to some extent blackish or grayish. Here it's whitish. So we have whitish opacity here, whitish opacity here, whitish opacity here. You can ask yourself, either this opacity is homogeneous or heterogeneous. Okay, it's homogeneous, it's right, it's homogeneous opacity. So we have homogeneous opacification, homogeneous opacity, obliterating the field of the right lung. And has a certain feature. It has a rising to the axilla. The opacity has a rising to the axilla. So we are dealing with homogeneous opacity with rising to the axilla equal pleural effusion. So the pleural effusion is suspected when you see a homogeneous opacity in any of lung fields and rising to the axilla. And don't forget the angle, the costophrenic angle must be obliterated here. It is whitish. It means obliterated here. It's free. Here it's free. So obliteration of the costophrenic angle with homogeneous opacity and rising to the axilla equal pleural effusion. So what is the difference between this radiology and the previous one? As we said, the blackness, the degree of blackness outside the body is not like the degree of the blackness in the lung. So this lung is normal. There is some sort of bronchovascular marking or grayness not equal, or the degree of blackness not equal to the blackness outside the body. So this lung is normally when comparing to this. When comparing the other left lung, this blackness is more than this. This lung is more lucent or more black than this lung. And if you are concentrate more, you have this border of the right on the left hilum. It is the collapsed lung. So we are dealing with jet black opacification of the lung with border of the lung. So it's pneumothorax. Here, like this is the border of the lung. And this is jet black. The degree of blackness here is more than here. There is normal lung, and this is collapsed lung due to presence of air in the pleural cavity equals pneumothorax. Again, this is the normal lung. No, there is increase of degree of blackness, no bronchovascular marking, and by the way, this is the collapsed lung, and the degree of pneumothorax is severe or massive, making the mediastinum shifted. The cardiac border of the cardiac shadow is shifted totally to the left. This is called tension pneumothorax. So we have two diseases, and still now the two diseases are connecting to the pleura, the pleural effusion, presence of homogeneous opacification, homogeneous whiteness of the pleura, and another disease called homogeneous blackish of the pleura. The first one is presence of fluid, it's called pleural effusion. The second part is presence of excess air, and it's called pneumothorax. We'll go next to the third disease, and by the way, it's also disease of the pleural cavity. It's a mix between the first disease of the pleural effusion and the second disease of pneumothorax. So mix, we have air and fluid in the pleural cavity. By the way, pleural cavity has very small amount of fluid just for frictioning or allowing frictioning of postparietal and visceral pleura. When there is excess fluid, it's called pneumothorax. No air in the pleural cavity. When presence of air in the pleural cavity, we are dealing with pneumothorax. So here in this four films of X-ray, we have homogeneous opacity, obliterated costophrenic angle, but not rising to the axilla. It has a stenciled border or air fluid level, called air fluid level. Here, homogeneous opacity, obliterating costophrenic angle, and stenciled border or air fluid border. Here, like this, homogeneous opacity, obliteration of costophrenic angle. Obliteration of costophrenic angle means effusion. Not rising to the axilla, it means not simple effusion. There is another pathology. So the pathology here is presence of air above the fluids called hydropneumothorax. Presence of both air and the fluid. يبقى how to know the hydropneumothorax? يبقى homogeneous opacity, obliterating of costophrenic angle, just like the pleural effusion, but not rising to the axilla. Just have an air fluid level. Just have a stenciled border like this, like this. It's called hydropneumothorax. Presence of mix between the pleural effusion or fluid and air called hydropneumothorax. So to this extent, we have three diseases affecting the pleural cavity and can be diagnosed easily by chest X-ray. The first one is the pleural effusion, presence of homogeneous opacity or whitish opacity, obliteration of costophrenic angle. It's must obliterating costophrenic angle, and must rising to the axilla. If there is no rising to the axilla, so you can suspect another pathology or overlying pathology, like here in hydropneumothorax, presence of air beside the fluid, making the border not clear or not rising to the axilla, but making it flat border, or this is called air fluid level, and this is called hydropneumothorax. So we'll go next to another category of diseases. In comparing this chest X-rays with the previous, here we have obesity here, obesity here, obesity here, obesity here. But it's differ from the obesity we mentioned before in the pleural effusion. It's not homogeneous like the pleural effusion. It's called heterogeneous. So we have heterogeneous obesity, and this is the first difference between it and the obesity of the pleural effusion. Second difference, here we have the clear costophrenic angle, clear costophrenic angle, clear costophrenic angle, clear costophrenic angle. So we're not dealing with effusion. It's not homogeneous obesity and the free costophrenic angle. So we're dealing another disease. So heterogeneous obesity in any of the lung fields or both lung fields, it's called pneumonia, consolidation of the lungs, and the disease called pneumonia. So when you are presence of heterogeneous obesity, taking one loop like this, or taking both lung fields like this, both lung fields, and like this, taking one loop, so it's called pneumonia and infection or consolidation of the lung bearing. So what about these chest X-rays? It's a mix between two diseases we mentioned before, so we can take it at ease. These lung fields more or less normal. Here there is abnormality. Here there is homogeneous obesity like this, and there is obliteration of the angle. So we are dealing with a fluid. There is a fluid in the pleural cavity, but it's not rising to the axilla. It's not rising to the axilla like this. There is another overlying heterogeneous obesity. So we have homogeneous obesity, so it's effusion, pleural effusion. You are right. There is overlying heterogeneous obesity. We said homogeneous obesity, obliteration costophrenic angle equals pleural effusion, and heterogeneous obesity in the lung fields equal pneumonia. So we are dealing a patient complaining of pneumonia with complicated parapneumonic effusion, like this. Here it's more clear. You have homogeneous obesity in this place, and it's obliteration of the angle, and there is another obesity overlying it, heterogeneous obesity overlying it. So homogeneous obesity equals pleural effusion. Heterogeneous obesity equals pneumonia. So are dealing with a pneumonia with parapneumonic effusion. The last disease I want you to know by chest X-ray, it's called pulmonary embolism, or you can face it in the ER. How can you diagnose or suspect pulmonary embolism in the chest radiograph? The first one, we'll start with this. The first one, what is the abnormality in this? There is hypertranslucency in the right lung field more than the left lung field. It's not pneumothorax. Why? Because there is no lung borders visible. So there is hypertranslucency in the lung fields. It means that there is lung oligemia, or decrease of blood reaching the right lung. It equals right pulmonary embolism. The second sign you can see in the chest X-ray of pulmonary embolism patients, this obesity, it's called atelectatic band. It's like hairline structure. It's called atelectatic band. It's raised the suspicious of pulmonary embolism. You may see another pathology. It's called elevation of one copula. This is the copula of the diaphragm. It's elevated. The right copula is elevated more than 2 spaces in comparison with the left. It's another sign of pulmonary embolism. The last sign is this. This is a heterogeneous obesity, like the pneumonia, totally like the pneumonia or consolidation, but it has a specific or a unique feature, which is triangular in shape. When you are seeing a triangular in heterogeneous obesity, triangular in shape like this, with the base of the triangle at the pleura and the apex of the triangle at the hilum, it's equal pulmonary embolism. It's not true consolidation. It's called infarction. So any of these 4 clinical signs you may see in a patient of pulmonary embolism, and for you it is of less importance. It's just for fun. We'll go next to the next investigation you may use in the ER to diagnose the chest case, which is an ECG. As we said, the ECG has only 2 rules in the diagnosis of chest diseases. The first rule is to exclude cardiac causes. The second rule is to aid in the diagnosis of pulmonary embolism beside the chest X-ray, the ECG and chest X-ray. Raise the suspicious or give the suspicious about the pulmonary embolism, but the gold standard of diagnosis of pulmonary embolism is the CT pulmonary angio. So we said the ECG has a rule to exclude in exclusion of cardiac cause. The most important cardiac cause you must exclude in the ER is the MI. What's the changes in the MI? This is a normal QRST complex. Here we have ST segment elevation. The first change occurring in the MI. Then there is ST segment elevation beside the pathological Q. This is ST segment elevation. Then we have ST segment flattening and the pathological Q. Lastly, the pathological presence of pathological Q. If a presence of one of these four changes equal MI, and this is the first rule of ECG in the chest is to exclude cardiac cause. Presence of this, it means that the patient is cardiological case, not a chest case. The second is to know the ECG changes of the pulmonary embolism. We have what's called S1. This means deep S1, deep S in the lead 1. And the next is Q3, the presence of deep Q in lead 3. The third is inverted T in the lead 3. So we have S1, Q3, T3 better is equal pulmonary embolism is ECG. We'll go next to the third item of chest diagnostic, and the last item which is called the ABG or arterial blood gas. What are the information we'll obtain from the ABG or ABG sample drawn from the patient? We are searching for what? We are searching for the oxygenation, the level of oxygenation of the patient. The next is seeking about the ventilation. The last is acid-base status. So we are searching or obtaining information about the oxygenation, ventilation, and acid-base status. How to comment on oxygenation? We have two figures searching for it. The first figure is the PO2 or partial oxygen pressure, and the second figure is the oxygen saturation. You must know the normal figure to know the abnormality. The normal PO2 tension is more than 80 millimeter mercury. The normal oxygen saturation is more than 95%. So less than this is called deficiency of oxygenation or hypoxemia or what's called type 1 respiratory failure. So if the PO2 tension or oxygen saturation below this figure, so the patient has what's called hypoxemia or type 1 respiratory failure. So below this, we call hypoxemia. There is a grade of hypoxemia or grade of type 1 respiratory failure. This table shows the grades of type 1 respiratory failure. We have mild, 3 grades, mild, moderate, and severe. We'll go to the PO2 like this. The mild is from 60 to 79. Moderate from 40 to 59. Less than 40 is severe. As regards to saturation, when it's between 90 and 94, it's mild. Between 75 and 89 is moderate. Below 75 is severe. So after we obtain or we catch the figure of PO2 and saturation below the normal value, so must categorize the patient either moderate, mild, or moderate or severe type 1 respiratory failure. The second comment or the second figure we will search about it is the PaO2 or the partial pressure of CO2. Carbon dioxide is a marker of ventilation. Means when the patient is hypoventilation, there is deficient of ventilation, there is a rise of carbon dioxide level. When the patient is hypoventilated, there is a rise of carbon dioxide level. When the patient is hyperventilated, so hyperventilation equals excess removal of CO2, so the patient will have a hypo level or decreased level of partial CO2 pressure. And this table shows that the euthyroid patient or the normal patient has a level of partial CO2 between 35 to 45, and it's normal ventilation. If the level of CO2 is higher than the normal, so the patient is hypoventilated. He can't get rid of the excess CO2, is hypoventilated. When the patient is tachypneic or has a rapid respiratory rate, so he will get rid of more than need of CO2, so the patient is called hyperventilation, and the figure will be below the lower limit, which is 35. The third item we are searching for in the ABG is called the acid-base status. How to comment on the acid-base status? The first, we must see three figures with the pH and the CO2 and the bicarbonate level. The normal pH is 7.35 to 7.45. The normal figure of CO2 is 35 to 45, as we mentioned before. The normal figure of bicarbonate is 22 to 26. So what are the abnormalities you will face in the commenting on acid-base status? We have the patient may be normal or have one of the four abnormalities. The first one is the metabolic acidosis. The next one is the metabolic alkalosis, then respiratory acidosis, then respiratory alkalosis. How you can know it's metabolic, or how you know it's acidosis alkalosis? Acidosis alkalosis according to the pH. When the pH is low, so you are dealing with acidosis. When the pH is high, you are dealing with alkalosis. How to know it is a respiratory problem or a metabolic problem? We know that the CO2 is responsible for the acid part, and the bicarbonate is responsible for the alkalosis. So when you have increase in the CO2, this is called the respiratory problem. When you have increase in the bicarbonate, this is metabolic problem. And you can use this word pH changes with the CO2. It means metabolic. And when the pH increase with the CO2 increase, so it is metabolic. The W can be reversed to M. When the pH changes with the CO2, you are dealing with a metabolic problem. When the pH changes against the CO2, you are dealing with respiratory problem. So we have algorithm with stepwise ABG interpretation. The first item will comment on oxygenation. We'll check the CO2 and oxygen saturation and oxygen tension. You have two abnormalities. Maybe normal. It's normal. It's okay. The patient has no abnormalities in the oxygenation, or it may be low. So it's type 1 respiratory failure when it's low. Then you will check the value of tension and saturation to detect the severity, as this table shows. The next comment or the next item is to search for ventilation. You will check for the oxygen CO2 tension. As a normal value is 35 to 45. When it's less than 35, the patient is hyperventilated. In the normal range, it's normal, and more than this is called type 2 respiratory failure or hypoventilation. Hypoventilation equals type 2 respiratory failure. The last algorithm is for the acid base. You will check the pH. You have three possibilities. Maybe lower than 7.35, or between the normal range 7.35 to 7.45, or more than 7.45. And the normal range is normal. Below that it's acidosis, more than it's alkalosis. So after that you will check the BCO2 level. When the CO2 level is high, so we are dealing with respiratory acidosis. Low, we are dealing with metabolic acidosis. If there is alkalosis, you will check the bicarb. When the bicarb is high, you are dealing with metabolic alkalosis. When the bicarb is low, you are dealing with respiratory alkalosis. These cases, you can use it as an example of how to interpret ABG. The first will comment on the oxygenation. We'll look for the both PO2 tension and saturation. They are both low. Below the normal range, you are dealing with type 1 respiratory failure or hypoxemia. Then we go to the next item, or the next comment is the BCO2. The BCO2 level is higher than normal, so the patient is hypoventilated, or the patient has type 2 respiratory failure. The next third item is a comment on acid-base status. Here the pH is 7.25, so it's lower than normal, so this is acidosis. we will see the bicarbonate level. The bicarbonate level is low and CO2 level is high. So the CO2 level is high. The change in the pH here decreased, and the CO2 increased. So it is respiratory acidosis. The next case, we'll comment firstly on the oxygenation. We have oxygen tension 82 and the saturation 97. So are dealing normal. The patient is normoxemic or no abnormalities in the oxygenation. We'll go next to the CO2 level. CO2 level is much lower than normal, 17. So the patient is hyperventilated. As regards the acid-base status, here we have 7.33. There is acidosis. Here the bicarbonate level is 4, which is very, very, very low. So the patient we are dealing with a metabolic acidosis. So at the end of our lectures, we must know lastly what is the cause of hemoptysis as a main alarming sign you may face in the ER. The cause of hemoptysis can be summarized in the word battle camp: bronchitis, bronchiectasis, aspergilloma, tumor, tuberculosis, lung abscess, emboli, coagulopathy, autoimmune disorders, AV malformation, alveolar hemorrhage, mitral stenosis, and pneumonia. Lastly, we'll go back to the case scenario we said before. The 6 patients we said that in the first slide. 6 patients complaining of dyspnea, chest pain, and blood tinges sputum. And after the investigation, the 6 patients has 3 different ways. So you will apply what we said about the chest diagnostics and know why these 6 patients has different 6 ways. This was the first patient chest X-ray. We did chest X-ray. This was the chest X-ray. What is the abnormalities here? We have heterogeneous obesity. So are dealing with pneumonia, but don't forget it has a triangular shape with the base toward the pleura and the apex toward the hilum. So it's suspicious of pulmonary embolism. And by the way, the CT confirmed it. This was the ECG changes here. We have S1, as we said, Q3, and inverted T in lead 3, lead T3. So we have Q1, S1, Q3, T3 pattern, which is pathognomonic for the pulmonary embolism. And this is what the EBG of this patient. We have oxygen saturation 70 and tension 40. The patient has type 1 respiratory failure. CO2 level is 22. The patient is hyperventilated. It means that the patient is tachypnic. Those hyperventilated. Acid-base status more or less normal. So the patient was admitted ICU due to presence of pulmonary embolism. So instead of the patient has same problem like the other 6, but it was admitted in the ICU, chest ICU. This was the next patient or the second patient. This is the radiology of the patient. It's more or less free. And this is the ECG of this patient. Just sinus tachycardia. The patient is tachycardic only. But the EBG, as we know, the patient has oxygen saturation below normal, so the patient is hypoxemic. The CO2 is high, so the patient has type 2 respiratory failure. And as regards the acid-base status, there is acidosis here with higher PCO2 respiratory acidosis. So the patient was admitted to intermediate care facility for non-invasive ventilation. Non-invasive ventilation for what? For decreasing the CO2 level or treating the hypoventilation. This is what the third patient. This is the chest X-ray of the third patient. As we said, this is heterogeneous obesity, so it may be pneumonia. Chest ECG changes. I think it's not no pathognomonic ECG changes. And as regard the EBG, I think it is more or less normal. No hypoxemia. The CO2 in the normal level and the pH is the normal level. So the patient we are dealing with a pneumonia patient with pneumonia. So it may be treated with a chest ward. So this patient was admitted in chest ward. Again, instead of the presence of the same symptoms in these 3 patients, if each one was admitted in a different department due to this is highlighting the role of the chest diagnosis. This was the fourth patient, chest X-ray. I think there is homogeneous obesity rising to the axilla. here, but here it is clear costophrenic angle. There is heterogeneous opacity here. It may be pneumonia, parapneumonic effusion, and so on. We will continue. This is the ECG changes. We have the ECG changes of the MI, and the patient has normal EBG, so the patient was transmitted to the cardiological department due to presence of the MI. And by the way, this chest X-ray, it's not pneumonia, it is pulmonary edema. This is the next patient. It has a chest X-ray. As we said, this is the collapsed lung. There is a jet blackness here, even compared to this. There is no much more ECG changes. The ABG is normal, so this patient was transferred to cardiothoracic department for chest tube drainage of the pleural effusion. The last case, or the sixth case, has a normal chest X-ray, normal ECG, normal EBG. So this patient was diagnosed as acute bronchitis and received the home treatment and go home. And lastly, thank you.